Hey everyone, it's Dr. Veronica Howard. So we're picking up now in another video in our series on punishment. What we've talked about so far are the history of mental health treatment. We've talked about some of the inhumane ways in which behavior has been changed. In our last video, we talked strictly about conceptually what is punishment. And when we're talking about punishment, remember we're using the functional definition, the way in which behavior change actually occurs, not necessarily focusing on whether or not the stimulus that's being used is aversive. Remember that what functions as a punisher for you may be different than what functions as a punisher for me, and stimuli that we may think are punishers may not be. Things that we think are pleasant and should be reinforcers may function as punishers. So it's very important to always focus on the functional use of procedures and really carefully analyze what's happening with the client's behavior to see whether what you think is a reinforcer really is, what you think is a punisher really is. Now, what I want to do is segue just really briefly here and talk about some ethical considerations when we're talking about punishment, give you some context here about how behavior analysts really talk about punishment and what some other professional agencies say when we talk about this use. We're also going to be talking about the clinical use of punishment. So if you decide that ethically it is acceptable to use punishment, what are some things that you want to be aware of, and what are the best practices around the use of punishment? So remember, this content is extremely controversial, and I hope that when you're done with this video, you will see that you shouldn't necessarily use punishment. We should be finding alternatives, better suggestions, better alternatives to using punishment. We should be teaching functional skills, not focusing on behavior deceleration at the expense of teaching functional skills. So let's get right into it, okay? Okay, so to understand punishment, let's talk first about the ethics of punishment and the use of punishment. When we're considering whether it's appropriate to use this procedure, we have to consider that this is a question of your personal morals as well as the professional ethics or the rules that your particular profession has regarding these procedures. Now, if you're watching this, you may find that you will someday become a psychologist, or you are a psychologist, an APA certified psychologist, or you're a certified counselor or social worker or a behavior analyst. All of these are professional organizations that have their own set of guidelines and their own professional ethics. So let's see where that fits in, right? Let's see where we're talking about punishment as defined by our professional organizations, but also what about our culture as a whole? We see that our culture speaks out against at least some forms of punishment because our Constitution says that we will not be using cruel and unusual forms of punishment. Again, remember, this is a reaction to some of those behavior change procedures that I described for you in the first video, this history of mental health treatment. At the time that America declared its independence, Americans were tired of this idea of people being sent to jail for stealing or being killed, being actually sent to the gallows and murdered for minor crimes. So in this case, this is a reaction to English law where even minor infractions would receive significant aversive control. But what does it mean to be cruel? What does it mean to be unusual? The terms aren't really defined in the Constitution, so in terms of a behavioral definition, we don't really know what this means. Can we then consider what is usual? What kind of usual behavior change procedure are we talking about? Well, consider the behavior of spanking. We know that in 1957, 99% of parents, or almost all parents, reported that they had spanked their children. Right? I would be willing to bet dollars to donuts that many people watching this video right now experienced some form of corporal aversive control as children. And the majority of people will tell me that, yeah, their parents probably swatted them once or twice. Some folks may have experienced more significant aversive control, and this topic may be uncomfortable for some viewers. So I would encourage you, if this is bringing up some information, if this is bringing up some feelings for you that are very uncomfortable, it's not harmful to reach out and talk to somebody about this. Now, in 1957, we should argue that punishment in the form of spanking was usual, like it or not. But that trend continues. So at least in some way in 2007, 57% of California parents reported that they would oppose a law banning parents from spanking their children. What they mean is they do not want to restrict parents from using behavior change procedures like spanking. And in 2014, as many as 80% of parents around the world in various studies are reporting that they use spanking as a behavior change procedure. But how can we reconcile this when we know that the American Medical Association has condemned the use of spanking? They consider behavior like this to be an inappropriate behavior change procedure. The American Medical Association is not for the use of aversive control. What can we say about that? Well, is this just spanking? Are we just talking about spanking as a behavior change procedure? No. I've argued this before and I will argue it again. We use aversive control. We use punishment as the most common form of behavior control in our modern life. Okay, this was true when Skinner wrote it in 1953. That's true now. What happens when you don't pay your taxes? Someone's going to come to you and tell you you have to pay your taxes or else. What happens when you mess up at work? Boss is going to fire you. You could get yelled at, but if it happens again and again, you're likely to lose your job. What happens when you speed? Well, police are going to give you a monetary fine. If you do it often enough, you may lose the freedom. You may lose your license. That's the removal of a stimulus. We're talking about negative punishment there. Kids in school, if they're misbehaving, acting out, they're likely to get detention. They may get in-school or out-of-school suspension. We find that judges continue to sentence people to prison, sometimes even for very minor crimes like the repeated possession or selling of controlled substances. We find that when you're in prison, your warden is probably going to use some of these behavior change procedures as aversive control, like solitary confinement or the restriction of access to privileges. And in the military, during times of war, it's even acceptable and appropriate to shoot a deserter in a time of war. So we see that even throughout our entire society, we still use some form of punishment, even though we consider spanking or corporal punishment to be dangerous or ineffective. Now, behaviorists, for the most part, are against the use of punishment because we're talking about the function and the form. Skinner argues that when you punish someone, you're not necessarily teaching a replacement behavior. Skinner argues that a person who's been punished is not necessarily less inclined to behave in that way. Sure, they're less likely to do it with you. They're less likely to do it under the circumstances associated with when they were punished or when that behavior was punished for them in the past. But the behavior itself is still there. It's still in the learner's repertoire. They already know what they're doing. Instead, Skinner argues that when we use punishment, we're not decreasing their behavior. We're teaching them when to do it. When is it safe to do it? So it becomes kind of discriminated. You can do it under these circumstances, but not these circumstances. Think about the ways in which we learn to get away with stuff, right? You can speed, but just so long as there's no cops around. Or maybe you can, for students, maybe you can plagiarize, but only if you use a little bit and you change the word so you don't get caught, right? So we're not teaching people to not do stuff. That's not how teaching works. We're teaching people under what circumstances it's okay to get away with the stuff we don't want them to do. So it doesn't make much sense to teach behavior using punishment because punishment can't increase behavior. Punishment doesn't teach behavior. Punishment teaches you to avoid. What about other psychological associations? Well, the APA talks about the use of punishment and they suggest that it's acceptable or it could be used, but only if three criteria are met. Three very important criteria. First, behavior has to be harmful. So going back to dangerous, it has to be harmful to the client or people around the client. It has to be a procedure that either the client or the caregiver, preferably both, consent to. And it has to be shown. You have to demonstrate as the behavior change agent, you have to demonstrate as the psychologist that all other procedures, you've attempted to use everything else to change this behavior, and you've used them with fidelity, you've used them correctly, and it's still not effective, right? Only then should you even consider the use of punishment. It isn't a guarantee, right? If you get to this point and you say, well, I guess the behavior is really not that bad, I guess we can live with it, you don't have to use punishment. But what I want you to take away from this is that punishment is an intervention of last resort. And even if these three criteria are met, that doesn't mean that you have to use punishment, right? You may then have to, at that point, determine a cost-benefit analysis of whether it's even worth using, given all of the potential side effects, given the headache associated with issues like contrast effect and emotional side effects, and the potential harm that you could do to the relationship with your client through the use of punishment. Now, when we talk about an intervention of last resort, I want to introduce you to this idea of the humane hierarchy. What we're talking about here is just kind of a heuristic or a rule of thumb that shows you that you should be trying everything else when changing behavior so that you don't have to use punishment. When you have a client present with an issue, the first thing you want to do is check, have we done everything we can? Have we ruled out any possible medical conditions? Could it be that there's something going on physically with the client? Are they sick? Do they have a medical illness that could cause this behavior? For example, when working with a community agency for folks who experience intellectual and developmental disabilities, we had a client who presented with severe head banging and would hit her head with her hand, with her open palm, with her fist. She would hit her head against the wall, against tables. And as a behaviorist, the first thing you do is check for medical concerns. And sure enough, when she was examined, the doctor discovered that she had profound head lice that nobody had noticed because of the color of her hair. No one had noticed how bad the head lice was. So this self-injury, this behavior was being used to manage that pain and that itch that would come from having head lice. So start with nutritional, start with physical. Figure out if there's something going on like IBS that could explain why this behavior is occurring. Next, we might go to what we call an antecedent intervention, and we'll come back in Unit 3 to talk about the antecedent to behavior, or the environment, the context in which behavior occurs. This could be things like providing instructions beforehand, making sure that the environment is really setting the stage or setting the occasion for desirable behavior, not undesirable behavior. But then you notice that the first intervention, the first true behavior intervention procedure that we recommend is positive reinforcement. Even when trying to decrease a problem behavior, you still want to use positive reinforcement. You want to ask yourself, well, is the client able to earn the reinforcer, whatever the problem behavior is paying off with? Are they able to earn that in other ways, right? If not, if this is the only way it pays off, well, you've got a big problem, because now the client, this is the only thing they have in their repertoire that contacts that skill. Why haven't we taught something else? So then we talk about differential reinforcement. Now we're going to teach the replacement behavior. We're going to make sure that pays off, not the problem behavior. Reinforce this, don't reinforce that. If that doesn't work, you can try extinction for the problem behavior. You could try other procedures like negative reinforcement or negative punishment, which are still pretty aversive. These are getting into much more aversive territory. And then finally is an intervention of very, very last resort, punishment. Specifically positive punishment, or the application of an aversive stimulus contingent on behavior to reduce the problem behavior. But you see there's a long list of behavior change procedures here that should be used before ever using punishment, ever. And I'm confident that most people can find something that is going to solve that problem without ever getting to the point of having to use punishment. Right? It's only going to be under extremely significant concerns do we even consider the use of punishment. We have two things to consider here. First, we have this idea that folks are entitled to the least restrictive environment possible, the least restrictive environment necessary to manage their behavior. This means that you have to be sure that all of those less restrictive, less harmful, less controlling and aversive procedures have been used, that they've been used correctly, that we have demonstrated that they were not effective, and we have implemented them in a way that they would be maximally effective, that we've used those first. We also need to keep in mind that informed consent is really important here. If you ever consider the use of a behavior change procedure, be it reinforcement, differential reinforcement, extinction punishment, you still need to have informed consent. This means that the individual, if they're capable, and their guardians are going to review and approve of that plan. That means that everyone has had an opportunity to discuss and fully understand the plan and what it means. Everyone should have the experience of whatever behavior change procedure we're talking about. So if you, the clinician, are recommending that we're going to use a brief electric shock with the client to reduce the behavior, you should experience the brief electric shock, right? That's one of the ways that we help make sure that we're not recommending treatments for other people, right? For them, for our clients, for other people that we wouldn't be comfortable using on ourselves. And if you get to a place where you're recommending something that you wouldn't want happen to you, why are you using it with a client? And then finally, we want a very open kind of behavior change procedure. So when you're considering the use of a behavior change procedure, people should know about it. This shouldn't be a secret. We shouldn't hide it away, because why would you hide it away? If you're ashamed or concerned about the procedures that you use, does that mean you shouldn't use them? I think so. Now, does that mean that you reveal the information about your client? Like, this is Steve and we're going to use punishment on Steve? No, of course not, because we protect our client's privacy and their rights. But if you say, I use brief electric shock to reduce self-injurious behavior, you should be able to state that openly and publicly and defend why you do so. Now, that doesn't mean, again, that everyone is going to use punishment. We actually see that many folks are not comfortable with using punishment personally or professionally. Many professional organizations oppose the use of aversive control under any circumstances. For them, it doesn't matter how severe the problem behavior is. And we find organizations such as the many departments of education, such as positive behavior intervention and supports organizations. Many of them are not going to support the use of punishment, and it's their right to do so. Saying that you favor the use of punishment is incredibly unpopular. But in order to understand behavior change, in order to help benefit our clients the most, what can you do? What do you do when you've tried everything else and all of the other behavior change procedures have been found ineffective? Now, what I want to do now is move on to a more conceptual discussion of some behavior change procedures. When I'm talking about these applications of punishment, I want to be extremely clear here. This does not mean, because we've demonstrated it to be effective in clinical practice in published studies, this does not mean that an untrained, uncertified, non-professional should use punishment because it's been used here. These applications that I'm about to show you were under extremely controlled conditions. All of these studies had some form of clinical review prior to the use of the punishment procedures. These behaviors that were intervened on were dangerous or disruptive or disgusting, or in some way we set the criteria that, remember, it's harmful to the client or others around them, that other behavior change procedures have been found ineffective even when used correctly, and their guardians consent to the use of this punisher, right? So when we're talking about treating the most severe, the most egregious, the most dangerous of behaviors, you really need to be sure, if you choose to use punishment and you've met all of those criteria, use it effectively. We're going to come back to this when we talk about the principles of effective reinforcement. But this is a little bit counterintuitive for some. When you use punishment, you have to make sure that your punishment procedure, that your punisher, your punishing stimulus, is used infrequently. If you're just giving punisher, 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 what's going to happen is that stimulus is no longer effective because the client will habituate to the stimulus. It will no longer produce in them the effect that it should. Think about relationships where all you ever hear from the person is criticism. You eventually learn to tune that person out. So if you use a punisher, use it sparingly, use it infrequently. But if you do use a punisher, use it immediately. Immediately contingent on the target behavior is when the aversive stimulus should be delivered. You also want to make sure that when you're using a punisher, you start with a larger punisher perhaps even larger than you think you may need to. Because again, going back to that idea of habituation, if you start small and then ramp up slowly, it's kind of like having a frog in a pot of water. You start tepid and then you raise the temperature, the frog won't notice that the water is boiling. When you start with a client with a small punisher and you ramp it up, they're going to follow with you, and it's not going to be effective as if you had just started with the large punisher. And then last, remember that when we're talking about punishment, you have to be sure the punisher is delivered contingent on the desired behavior that you want to decrease. It shouldn't be delivered for other stuff. It should only be reserved for this one, and it should be delivered every single time the target behavior occurs, right? The behavior that we need to decrease. If you can't guarantee these criteria, and if you can't guarantee that a punishment procedure will be used with 100% fidelity, don't do it. Right? If you can't guarantee that it's going to be used right and it's going to be used effectively, don't do it, right? If you don't have the training to deliver this, if you don't have control over the environment in which the client lives, don't do it. Instead, get help, get resources, reach out for other alternative strategies. Let's talk about some literature. We see that when treating really problem behavior, in a meta-analysis, Hagopian and colleagues discovered that procedures that use only reinforcement for an alternative response, so we're going to talk about differential reinforcement soon, teaching an alternative response was effective sometimes, but pretty infrequently. They found that when we used what's called a differential reinforcement of other behavior, that means reinforcement for an alternative skill, plus the behavior doesn't pay off anymore, so you can engage in the problem behavior, but it's not going to pay off for you. That was more effective, about 45% effective. But the most effective behavior change procedures involve a combination of reinforcement for other stuff, teach an alternative target skill, plus punishment for the behavior that you need to have decreased, right? Doing just one, using just reinforcement as an alternative, using differential reinforcement where reinforcement for this but no reinforcement for the problem behavior, they're not as effective as reinforcement plus punishment. And that's because you have to consider the learning history of the organism, right? In these cases, you have folks who have used this behavior for a long, long time. In this case, when you're treating the problem behavior, reinforcement is ineffective because that alternative behavior, that thing that we're punishing, has been their MO for so long. It's paid off for them for so long that they're going to continue doing it through behavioral momentum. So when we talk about really severe behavior, you may have to consider the use of punishment. Now, should an untrained individual do it? No, of course not. These procedures that I'm presenting to you are highly controlled, experimental, in treatment facilities and hospitals. So for instance, Lang and Melamed. In this case, we're talking about a kid who was super, super tiny. I'm going to show you a photo in a moment. And this is a 9-month-old child who's weighing just 12 pounds, so just above birth weight at 9 months. And in this case, the child had persistent involuntary vomiting. And what would happen when the child would start to have precursor behaviors, when their stomach, the muscles in their stomach would start to ripple in a way that the EMG suggested would be associated with vomiting. There was a brief electric shock delivered to the child's leg, right? So it's a tiny shock, just bzz, and then the muscles would stop. There would be no vomiting. So in this case, the clinicians demonstrated that in 6 sessions, this baby, a 9-month-old baby, right, who looked like this, very close to death, was through punishment capable of no longer involuntarily vomiting. Now, the follow-up here is that the infant actually saw a lot of improvement. We saw that with just those 6 sessions, the baby not only stopped vomiting, but at follow-up, this is a 5-month follow-up, so 14 months, the child was typically developing. They were in the right size, the percentile for their particular age. Now, this study was published in 1969. And I'm really pleased to report that we've had a lot of published literature since this study. We have a lot of strategies where we can intervene earlier when the infant can't keep food down. We have feeding strategies to reduce food refusal. We have a lot of non-aversive procedures that we can now use that we didn't have at the time. But this would be perhaps considered an acceptable use because this behavior was, of course, dangerous. The child would have died if they had not experienced punishment. The parents had consented and they had tried other procedures first, but they simply weren't effective. What do we know about client preference? So do we ask people, do you want to experience punishment? We would think that most people would say, no, no, no punishment. But in one study by Hanley and colleagues, children were allowed to choose conditions to determine whether or not they wanted to try a procedure where they would technically experience functional punishment. So in this case, Hanley gave them 3 different conditions. And one, the children could ask for attention, and attention was the reinforcer for the target behavior. They were taught to ask for the reinforcer, and that behavior was reinforced. So if if attention is your reinforcer, if you want attention, just ask me for it. Or if you can't talk, just give me the card that says you want my attention. In the next condition, the same procedure happened. They could request attention, but for target behavior that was dangerous or disruptive, the children experienced a brief timeout procedure. So if attention is the reinforcer, what we're talking about here is the kids would be response blocked, right? The researcher would turn away, so they no longer had that attention, they would be blocked. And in the third condition, there was never an opportunity to earn attention. Instead, the kids would only experience response blocking. They would not have an opportunity to earn attention. Well, why would we do that? We want to see if people will actually choose a condition where they get just attention. What you might expect is that kids will prefer just attention. They'll ask for just attention. But in this case, when given an opportunity to choose, we see that the clients actually demonstrated a preference for the condition where they could ask for attention, and then if they engaged in undesirable behavior, the researcher would do a brief timeout. So we see that this is not uncommon. Just like we saw before, where functional reinforcement plus punishment was the most effective behavior change procedure, in this study, we see that it's also the most preferred procedure for clients. We also see this in other places where a person may choose to be in a condition where they experience punishment. So check out the video that I've posted on our Blackboard site. This is a video of Mary, a client who's got severe self-injurious behavior so severe that she's going to detach her retinas. In this case, she's referred to this treatment facility in Florida because her parents are so worried. And you'll see in the video, she actually does physical harm to her face where she's bleeding and her lip is cut. And she's doing this behavior to herself. She's hitting her own face against this wheelchair and actually harming herself. So in this case, what we're talking about is a procedure where Mary would be given this self-injury behavior inhibition system. It's called SIVUS. And what this means is anytime the helmet detects movement at greater than normal acceleration or velocity, when the helmet feels her jerking her head like that, there's a brief electric shock again to the thigh, because that's a safe place to deliver or administer a brief electric shock. The behavior analysts in this case tried other procedures. They tried differential reinforcement and extinction, and they were not quite capable of figuring out the function of the self-injury because it occurred all the time, which suggested that it may have served an automatic reinforcement function. It may have simply been stimulation that was reinforcing. So in this case, they used that self-injury inhibition system, or the SIVUS helmet, and you see a dramatic reduction in self-injury. But what's most striking about this video is that you actually see Mary reach for the helmet when they come back, and she works with the researcher to help get the helmet back on. Now, this shouldn't really surprise us because many times we may want to change our own behavior, right? 70% of Americans report that they want to quit smoking, yet only 3% do. Even though we can articulate that we know when our own behavior is harmful, we may not be capable of changing that behavior. without some form of really outrageous or really unusual, some form of intervention that can help us, right? Help us help ourselves. Now, what I want you to take away from this is, remember, punishment is extremely controversial. And we know that not everyone is going to consent to the use of punishment. We know that many professional organizations completely oppose the use of punishment, or if they do support the use of punishment, it's only under very limited circumstances. We know that behaviors, for the most part, understand using punishment doesn't increase the behavior that you want to see. It only decreases behavior you don't want to see. And for that matter, it doesn't really decrease the behavior that you don't want to see everywhere. It just reduces it under a very small set of circumstances. So punishment as a clinical procedure should be used so sparingly. It should never be used by an untrained individual. It should not be used in the way that our culture uses it, which is just willy-nilly, do it or else there will be consequences if you don't comply. So when you take away from this, please just remember that what we're talking about is a very controversial procedure. You hope, I pray that you never find yourself in a position where you're working with a client who would even qualify for the use of punishment. And if you have any comments or concerns, of course, send me an email, leave a comment in the description or in the space below. But I look forward to hearing what you have to say about this. And I think that we owe it to ourselves as practitioners, and we owe it to society to continue fostering a science that better understands behavior. We better understand the circumstances under which behavior really changes and what's effective, so that we don't have to resort to these procedures as that intervention of last resort. I'll see you guys next time.